Hypersensitivities. A hypersensitivity is an exaggerated immune response to typically harmless antigen. In other words, your immune system overreacts to something that it shouldn't be reacting to. It results in tissue injury and disease. There's 4 main categories of hypersensitivity: type 1, 2, 3, and 4. And they're called type 1 hypersensitivity, type 2 hypersensitivity, and so forth. Immediate reactions develop minutes to hours after the antigen exposure. That's type 1, 2, and 3. And then there's delayed reactions, which develop 24 to 48 hours after antigen exposure. And those are the type 4 hypersensitivities. Type 1 hypersensitivity are your typical allergic reactions, also known as anaphylactic hypersensitivity. Commonly occur within minutes after exposure to an allergen. The key components are IgE, mast cells, basophils, and eosinophils. So typically what has to happen is you have to be exposed to the allergen in a primary exposure before you'll actually develop symptoms of the allergy. There's the sensitization phase, where you first get exposed to it for the first time in your life. So like, for example, my kid's got a tree nut allergy. He ate cashews once in his life, no problem. But the second time he had cashews in his life, he had this major allergic reaction. So the sensitization phase really happens the first time you're exposed to this allergen. The antigen-presenting cells process the allergen and present them to helper T cells. Th2 cells in particular induce the production of allergen-specific IgE. So what's going to happen is an antigen-presenting cell is going to consume the allergen, process it, and present it. Then these Th2 helper T cells are going to go find and present it to a B cell. When the B cell finds it, that B cell is going to start to go through that change, immunoglobulin isotype switching, where it goes from a B cell to a plasma cell, and it goes from having IgG or IgM or D on the surface to start pumping out IgE antibody. So now we have IgE antibody that's going to be produced by those plasma cells, and the plasma cells keep pumping out that IgE. Now you've got a concentration of IgE that's primed and ready to respond against the allergen. This IgE antibody is going to bind to special receptors, Fc epsilon Ri receptors, on the surface of mast cells and basophils. And when they bind, now you have sensitized or primed mast cells. The second time that a person is exposed to that allergen, the allergen is going to come into the body, and you have the activation phase. During that activation phase, the allergen is going to cross-link with the IgE antibodies that are already on the surface of the mast cell or basophil. Mast cells and basophils are going to degranulate, which means the granules that are inside of them are going to release the chemicals. And those chemicals are what causes the allergic reaction. The chemicals are going to bind to those target organs, and the allergy symptoms are produced. Common allergens are listed here. Most people are familiar with common allergens. Clinical manifestations, so rhinitis or hay fever, asthma, food allergies, hives, eczema, or systemic anaphylaxis. Systemic anaphylaxis is a potential fatal reaction where the chemicals that are released are going to have body-wide effects through the bloodstream, and it can cause the constriction of blood flow to key organs. It can cause constriction of the airway, and all of those symptoms can lead to death if not treated. Treatments would be avoid the allergen. A lot of people think that if you keep consuming, like if you have a food allergy, if you keep consuming low amounts of the allergen, then you're not going to have a major reaction but you think that, or they think that they're sensitizing themselves to that. They're actually stimulating the continued production of those IgE antibodies against the allergen. So it's more recommended that you don't touch that allergen, don't come in contact with that allergen for like 5 years, and then you can try again. Of course, you don't want to do like trial and error with something that's going to make you anaphylactic or have that major reaction where you could die from that. But typically you want to avoid the allergen. There is drug therapy available, so antihistamines, bronchodilators, mast cell stabilizers, corticosteroids, epinephrine, like an EpiPen. Epinephrine opens up the airways to prevent that airway constriction during an anaphylactic reaction. There's monoclonal anti-IgE antibody available, where we can block the activity of IgE antibody. And there's allergy immunotherapy, where you administer gradually increasing doses of the allergen, and that's in a controlled hospital environment under careful watch from a physician. You would never want to just do this on your own accord for the reasons I listed before. How do you test for hypersensitivity of type 1? Percutaneous or intradermal, so you would stick a small portion of the allergen into the skin. You wait 15 to 20 minutes, and a positive test would be a wheal and flare at the site of application. Then those are also measured, so you don't just look for them, you're also going to measure them. The wheal would be this raising bump in the center, and the flare would be the outstretch of the redness around it. Allergen-specific IgE testing. Now, it's important to note that just because someone has the antibodies against a particular allergen, it doesn't mean that they would actually have an allergic reaction if exposed. For example, my son with his tree nut allergy, he can eat peanuts all day long. He can have peanut butter, peanuts, anytime that he feels like having it, and he never has an allergic reaction. Although he does have IgE against peanuts, and when they did his blood testing, it came positive for peanuts. The doctor just said keep letting him have peanuts. As long as it's not causing the actual symptoms of an allergy, he can continue to consume it. But with allergen-specific IgE testing, what we do is we take antigens, so that's the known allergens. So if we're testing for IgE against peanuts, we would take the peanut antigens and stick it at the bottom of a well. And then we would put in the patient's serum. And if the patient's serum has those antibodies in it that are specific to recognize the peanut antigen, then they would bind. Then we're going to put a secondary antibody in there that's labeled. And it can be labeled with an enzyme or any of those other items that we discussed during our labeled immunoassay lecture. Then we are going to wash away any unbound antibody, and in this example, they were then adding a substrate, so this looks more like it was labeled with an enzyme, and it would cause a color change. And that color change would mean that this is positive for that allergen, or that antibody against that allergen. We can also test for total IgE in a specimen, so we can use anti-IgE antibodies, and we can quantify that through a series of dilutions and careful concentrations. Here it pictures forming a sandwich ELISA and labeling that, and then we can detect the color change in the medium and quantify that. So that's type 1 hypersensitivity. So that's your typical allergies. Key players would be that IgE and those mast cells. And you'd see mast cell degranulation releases those chemicals that cause the allergic reaction. Type 2 hypersensitivity is also known as antibody-mediated cytotoxic hypersensitivity. Key components would be IgG and IgM directed against a cell surface antigen. The effects of the antibodies include cell destruction, inhibition of cell function, or an increase in cell function. We have activation of the classical pathway of complement and cell lysis, opsonization and phagocytosis of the cell, Antibody-dependent cell-mediated cytotoxicity, ADCC, which is an important immune mechanism that plays a role in type 2 hypersensitivity reactions, which involve antibody-mediated destruction of cells. So basically what happens here is we have antibodies against the cell surface proteins or cell surface antigens. If those antibodies come in contact with those cells, they're going to stick. And that's going to trigger a cascade of effects that eventually leads to the activation of the complement classical pathway, and it's going to cause cell lysis. So massive amounts of cell lysis. Clinical examples would be transfusion reactions. So certain patients can only receive blood from certain types of blood types. And that's due to the antigens on the surface of their blood cells and the antibodies that they produce against foreign antigen. If you are given the wrong blood type, what happens is the antigens that are on the surface of your red blood cells are not compatible with the antibodies that are found in the incoming serum, or vice versa. The antibodies in your serum are not compatible with the antigen on the incoming blood cell. And if that happens, then the antibodies are going to bind to those antigens on the surface of the red blood cells, and it's going to cause those red blood cells to lyse open. That's going to release a lot of cellular waste and debris into the bloodstream and can cause some pretty terrible side effects from that. Hemolytic disease of the newborn is another one, which I'm just going to go forward to the picture here so you can learn a little bit about it right away, but it's caused by the development of antibodies by a pregnant woman to red blood group antigens, usually RHD, on the surface of red blood cells of the fetus. So if we talk about blood typing, usually when someone gives you their blood type, it's like AB positive or O negative. The positive and negative has to do with the presence of that ROGAM or that DRHD factor. So you either have it or you don't. The thing about that is that you don't automatically produce antibodies against it if you don't have it at birth. You have to be sensitized to it. So the first time you're exposed to it, you start to develop those antibodies. The second time you're exposed to it, you have those antibodies primed and ready to go, and it can destroy the blood cells of the developing fetus. So how can this happen? So if a mother is Rh negative, that means that this mother does not have that that Rh factor on the surface of its cells. And because that antigen is not on the surface of the cells, the mom never wants to come in contact with it. If the mom has an Rh positive baby, what's going to happen is the baby is going to start to produce their own red blood cells about halfway through gestation. And as the baby produces its own red blood cells, the mom is going to start producing antibodies against the baby's red blood cells. Because the mom doesn't have that antigen, the baby does. And then eventually, it's going to produce enough so that the baby would be lost. So the first pregnancy, it's typically treated with ROGAM. Every pregnancy is treated with ROGAM that prevents the antibodies from being produced, and from, if they are produced, it prevents them from actually harming the baby's red blood cells. First pregnancy is usually the priming phase where the mother first gets exposed to the positive baby and they start developing those antibodies. But by the time you have that second pregnancy, the antibodies are already there, and it can attack those red blood cells, and that can kill the baby. Autoimmune hemolytic anemia, warm reactive antibodies, cold agglutinins, or proximal cold hemoglobinuria, Goodpasture syndrome, and Hashimoto's disease are all other examples of type 2 hypersensitivities. The direct antiglobulin test, or DAT, detects red blood cells coated with complement components, or IgG antibody, by incubation with a polyspecific anti-human Ig directed against IgG and complement. If positive, so if you see agglutination, the test is repeated with monospecific anti-IgG, anti-C3b, and anti-C3d. The indirect antiglobulin test, also known as the Coombs test, tests patient's serum for antibodies to red blood cell antigens. The process: incubate reagent red blood cells with patient serum at 37°C, wash to remove excess. Then you add anti-human globulin. A positive test would be red blood cell agglutination. Type 3 hypersensitivities. So just as a review, type 1, we had that IgE, the mast cells, those are your typical allergic reactions. Type 2 is when you get like the wrong blood type or something similar to that, where there's something wrong with the cell surface. And you start to develop antibodies and complement is activated against cell surface proteins. Type 3 hypersensitivities is also known as complex mediated hypersensitivities. Key components are IgG and IgM directed against a soluble antigen. A soluble antigen would be something that's freely floating through the bloodstream. Small antigen-antibody complexes precipitate out and deposit in the tissues. Complement binds, and you see vasodilation and vasopermeability increase. Macrophages and neutrophils migrate to the affected areas and release their lysosomal enzymes, resulting in tissue damage. This is the classic pathway of activating the inflammatory response. So you've got allergens in there. The allergens stimulate the vasodilation, not allergens, antigens. Antigens are in there. The antigens stimulate vasodilation, vasopermeability caused by complement stimulation. And then you've got neutrophils and macrophages coming to the area to try to clean up the mess. In the meantime, they release lysosomal enzymes and ultimately cause tissue damage. So you have local inflammation caused by these immune complexes settling in the tissues. Arthus reaction is a skin reaction caused by type 3 hypersensitivity. There's localized inflammation characterized by redness and edema, and it peaks 3 to 8 hours. Serum sickness is a generalized type 3 hypersensitivity reaction that is caused by passive immunization of humans with animal serum. Produces antibodies against the foreign animal proteins in the patients. Those immune complexes, so the person's antibodies and the incoming animal antigen, form a complex and then deposit in the tissues. Symptoms include headache, fever, nausea, joint pain, rashes, and lymphadenopathy. Some autoimmune diseases, such as systemic lupus erythematosus, or SLE, and rheumatoid arthritis, or RA, reactions to bee stings, drug reactions, and the sequel to infections like post-streptococcal glomerulonephritis. So what happens in some of these situations? Let's just talk about a bee sting. When a bee stings you, it injects in a toxin, and that toxin is an antigen. So now you have an injection of antigen from the surface of the skin. If you have been primed, you have antibodies that are going to be against that antigen. The antibodies in your skin are going to form a complex with the incoming antigen that was just injected in by the bee stinger, and those are going to settle in the tissues. And then you can see a pretty overwhelming reaction that happens with the pain, the swelling, and the redness and the heat associated with the inflammatory response that happens there. Laboratory testing. So testing for ANAs. ANAs are anti-nuclear antibodies. Anti-nuclear antibodies are found, they're antibodies that are against certain cellular components related to the nucleus. So it could be the nucleus itself, DNA, RNA, components of the nucleus. These are elevated in certain types of autoimmune diseases. Fluorescent staining of tissue sections to detect deposited immune complexes. Testing for rheumatoid factor and anti-IgG. And testing complement levels may be decreased in the serum during periods of high disease activity. So we have type 4 hypersensitivity. So type 4 are also known as cell-mediated hypersensitivity or are delayed type hypersensitivities. They involve helper T cells, or Th1 in particular, and macrophages. Antigens presenting cells present the antigens to native T helper cells, which differentiate into Th1 cells. Th1 cells release cytokines that attract and activate macrophages. Then macrophages induce inflammation in the area, and cytotoxic T cells are recruited and destroy target cells. Hypersensitivity peaks 48 to 72 hours after antigen exposure. Clinical examples would be infections with intracellular pathogens, so tuberculosis or leprae, pneumocystis carnii, leishmania species, or herpes simplex virus, contact dermatitis, or hypersensitivity pneumonitis, allergic disease of the lungs caused by inhalation of bacteria and fungal spores. Examples include farmer's lung, bird breeder's lung disease, humidifier lung disease. In contact dermatitis, a low molecular weight compound contacts the skin and acts as haptens to sensitize Th1 cells. Examples include the oleoresins, or the oils of poison ivy, poison oak, nickel salts, minerals in cosmetics, hair and hair dyes, and latex. Skin eruptions occur with erythema, swelling, and papules. Skin testing for delayed hypersensitivity. There's a patch test. The antigen is applied to the skin surface, and it's a test for contact dermatitis. A positive test would be redness with papules or tiny blisters. The MAN2 method is the antigen is injected intradermally. Test for tuberculosis exposure, PPD, or T cell function. A positive test would be induration. So this is pictures of that skin testing for the delayed hypersensitivity, or TB skin testing. And you can review the summary pictures.